Welcome to the lab evaluation and monitoring of the newborn. So this is going to combine sort of initial labs and things that we look for in babies, and this a big part of it's going to look at bilirubin, especially with delayed cord clamping like we talked about in the labor and delivery presentation. Bilirubin is going to play a little role in NICU medicine. You're going to see it on most of your babies. Now we'll talk about what it means to us in more detail, but it's just something you should be aware of, and it's something that's out there. Not necessarily respiratory specific, but something that we should pay attention to, especially with delayed cord clamping and monitoring. We'll talk about different ways to monitoring these babies, including transcutaneous, end-tidal. Yes, I'm bringing back end-tidal CO2, as well as just basic pulse ox and respiratory monitoring. So all these are going to be important. So it's a long presentation, so remember to take breaks when you need to, but let's get started. All right, so this is the normal life cycle of a hemoglobin. So when a hemoglobin is no longer being used, so when it catabolizes, that's what we're looking at here. And the hemoglobin will break down into the hemigroup and the globin. So that's how it just sort of disintegrates, if you will. It just breaks down. And so the normal breakdown of the hemigroup, ultimately, when we're looking at this, here, let me use my stylus. So when we're looking at this, the normal breakdown of the hemigroup, it will break down into carbon monoxide. So your body naturally produces carbon monoxide, and that's okay. That helps you do a little bit of a left shift, especially at your lungs, which is great for oxygen attaching itself to the blood cell, to the red blood cell. But by the time it gets to the tissues, it should be pretty much disintegrated. So it breaks down to the carbon monoxide and to the biliverdin. It's the biliverdin that will ultimately break down into bilirubin. Now, this is naturally happening in your body right now. Right, so this is the bilirubin is the end product of catabolism of the hemoglobin. So what we're looking at here is just a normal natural process that happens in our body. As long as we have a functioning liver, or we don't have excessive destruction of red blood cells or the excessive production of red blood cells, which is what we see with these little guys, then we shouldn't have an issue with this. So a lot of this is having a healthy liver and good hydration status. You may have seen in critical care clinicals some individuals that have liver failure, and what color are they, right? They're that jaundice yellow. The sclera of their eyes are yellow, their skin is turning that yellow color, right? And that's what you're seeing there. Very similar thing, except for instead of just excessive red blood cell destruction, which is what causes bilirubin levels in the blood, there it's the fact that their liver is not converting the bilirubin to a form where it can be excreted by the body. So when we're looking at bilirubin, this is where we talk about conjugated versus unconjugated bilirubin. So conjugated bilirubin is where it's bound to albumin and transported by plasma. Then it combines with sugar. So this is another reason why we need good blood sugar on our babies, so blood glucose. And then it is water soluble, which means they can excrete it during the normal excretion process of the body. I'll let you figure out what that is. But that's what you're looking at here, is that normal excretion process of the body. So this can be excreted through the GI and the renal system when we're looking at it. So that's the traditional method, is have it be conjugated in the liver, right? So the big thing here is conjugated is going to be in the liver, right? And then that's where it is being made to be water soluble, and therefore it can be excreted from the body and the GI tract, right? The GI and the urine. So unconjugated bilirubin is what ultimately causes the bilirubin to not be able to be excreted by the body. In other words, the bilirubin will build up in the baby's system, and this is what can cause the baby to have high bilirubin levels, and it's called icterus when it gets built up high enough, right? So this is where it is in the body's tissues. It's called icterus, and it has a high plasma concentration filtration, which then causes that yellow pigment to occur. Now remember that yellow pigment's all over the place. It's in the skin, which is the most notable part, the eye, the sclera of the eye, mucous membranes, other tissues you might see it in there as well. So bilirubin altogether is highly soluble in water. So if a baby's dehydrated, or if their liver's not right, or they have excessive red blood cell destruction, the liver may not be able to catch up with all this extra blood volume, right? So it might not be able to convert that bilirubin, right, to a conjugated form. So some bilirubin might stay unconjugated, which then is fat soluble and cannot be excreted. So it's just going to keep building up and building up and building up in their bloodstream, right? So the whole idea is the liver is going to be an important aspect here, is to make sure the liver is conjugating the bilirubin, so that way they can get rid of it. If the liver cannot conjugate the bilirubin, it's going to stay in an unconjugated state, which is ultimately what causes, right, what ultimately causes our issue here. So bilirubin is formed in the liver and the spleen, right? And once it is fat soluble, it cannot be excreted if it's unconjugated. So we need that liver to conjugate it and get it out of the baby's system. So some of the drugs that we're going to be looking at later that we can use to help with this would include medicines that help with liver metabolism or improve liver metabolism. That's what we see with barbiturates. They actually increase liver metabolism as long as the baby has a healthy liver, and that's going to help that bilirubin become conjugated and therefore reduce their bili levels in their bloodstream. So this is an important slide. Understand that conjugated is good, right? Smiley face. Unconjugated is bad, right? And that cannot be excreted. One can be excreted. And so we need to make sure our babies have adequate blood sugar levels, blood glucose levels. We need to make sure that they're adequately hydrated. And we need to make sure their liver is functioning correctly. And that's going to be very helpful for conjugating bilirubin. Unconjugated bilirubin will just build up. Now, what's the most common cause of this? Well, what's the most common cause of these little guys getting jaundice? It's because they have excessive red blood cell destruction. So if I asked you on a future assessment document, what's the most common cause of jaundice, you're going to say excessive red blood cell destruction, and that's where you're going to go from there, right? And that's exactly what's going on with this patient population. Hyperbilirubinemia, right? This means we have a lot of bilirubin in the blood going on. So this is the inability to conjugate bilirubin. So previous slide, right? We talked about conjugated bilirubins is where it combines and it becomes water soluble and we can excrete it, and it's all good, right? It's out of our body system, right? So the inability to conjugate it would result in this level, a level over 6 milligrams per deciliter, right? So this looks like an important number I would want you to remember. I hope so anyway. So that's something that we'll be looking at with daily labs on especially premature babies or babies in the NICU that we might think, and even term babies get bili levels drawn as well. So it's something we watch on all sort of neonates or newborns, I should say, as well. So the kidneys, when it comes down to unconjugated bilirubin, so remember unconjugated bilirubin is the unsmiley face, right? Unsmiley face. They do not filter unconjugated bilirubin. Remember, they're not water soluble if they're unconjugated, so they can't filter it, right? They can't. And so it's all binding to albumin, right? The kidneys do not filter unconjugated bilirubin. So bilirubin in the urine indicates conjugated hyperbilirubin anemia. So that's something that we can actually look for in the urine as well if they have conjugated bilirubin going on. So that means that everything's working, their body's naturally doing this, and maybe we just need to augment with a phototherapy light, right? And we'll talk about phototherapy lights as one of the treatments upcoming soon. So if we see that there's a bilirubin level in the baby's urine, then that means that they're doing a good job. They're conjugating it. That doesn't mean it's doing 100% of the job, but it's doing a good job conjugating it and trying to eliminate it from their body. So what are the causes of hyperbilirubin anemia, or pretty much what we're looking at, or what are some of the causes of jaundice? Well, increased red blood cells is going to be the number one thing here. Now, I'm not talking about a delayed cord clamping yet. So we're talking about increased red blood cells because maybe the baby had decreased oxygen in utero. In other words, just like your COPD or just like your emphysema patient, where they actually develop polycythemia. Remember, we talked about that way back in disease class, that polycythemia is something that humans do as a compensatory mechanism for chronic hypoxemia. Well, this is very similar, almost exactly the same. The baby in utero has low oxygen levels, too low for what they're supposed to have. So the compensatory mechanism kicks in and produces more red blood cells, and that's what's happening here. So if a baby has a parent mom that smoked, anything like that, that would cause decreased intrauterine oxygen levels as far as the blood oxygen going to baby, right? There's no oxygen in the amniotic sac and all that stuff, right? So the oxygen being delivered to the umbilical cord through the placenta, that's what we're looking at here. So that will cause increased red blood cells. Well, that would then cause the baby to have more red blood cells to break down, and therefore more bilirubin that can build up in their system. So we just have to watch it on those kids. So we're going to watch their levels, and if their levels are climbing up there, then we're going to start looking at things like phototherapy. If it's really bad, we can do what's called an exchange transfusion, where we exchange part of their blood volume with red blood cells, saline, albumin, right? Things like that we can use. The other thing here is the shorter lifespan of red blood cells on neonates as well. So that means because they don't live as long, the shorter lifespan of the neonate, they're going to be a lot more destruction, a lot more breakdown, which goes back to our first slide there where we showed that flow chart of the breakdown. And so that's going to mean that we're going to have that continuous breakdown. That's going to be another factor that goes into increased bilirubin levels on your newborns. So the neonatal liver is the big part here. This is the big system that we're looking at. It's the liver is unable to conjugate excess bilirubin. So if they have a lot of red blood cell destruction because they're polycythemic, or because they got a blood transfusion, or because they got, you name it, intrauterine hypoxemia that then caused a lot of red blood cells, it's going to be an issue with those children. Now, does that mean we can't treat it? Absolutely not. It just means that makes them more prone to having high bilirubin levels. So unlike unconjugated bilirubin, conjugated bilirubin, which is the good stuff, right, does not bind to neural tissue. In other words, it doesn't have any brain effects, right? And this is where I'm going to talk about something here in a second. No brain effects, and it does not lead to Kern icterus, right? So we talked about icterus. Kern icterus is a form of bilirubin toxicity that can go to the brain and can cause a lot of neural damage on these babies. So if left untreated, right? If left untreated, that's what we're looking at here. Isn't that crazy? So we need to make sure that we're watching these kids, we're watching their levels, we're not letting it go too high. And it's something, high bilirubin levels has been around and been noted in studies since over 1,000 years ago. There was a Chinese textbook that talked about this type of thing, right? So even in the 18th and 19th centuries, they were talking about pretty much Kern icterus and icterus, right? They were talking about just the babies being yellow, as well as having neural issues like seizures and coma, things like that. Very, very, and it can be significant in some kids, right? And a lot of these kids, they didn't know what was going on, and it led to a lethal situation with these kids. especially if they had RH immunization issues, things like that. But it's a very significant brain altering, and it can cause seizures and comas and things like that. So kernicterus is where it crosses that blood-brain barrier. I'll repeat that again because you probably weren't listening. I'm just joking. Kernicterus is where it crosses that blood-brain barrier and can cause neuro issues, neurotoxicity. Morbidity and mortality are associated with conjugated hyperbilirubinemia resulting from the underlying disease process. In other words, their levels are so high that even their conjugated bilirubins are high as well. It's pretty crazy. So jaundice itself, it's the most common condition that requires medical attention and hospital readmission of the newborn. So this is a good general statement that you should read twice, and I'll repeat it twice. Jaundice is the most common condition that requires medical attention and hospital readmission in newborns. In other words, it's very, very common in newborn medicine, whether they're premature or term. It's one of those very, very common things that we'll see out there. That's one of the reasons why they'll have well baby visits. In other words, the baby will have to go and see their pediatrician, at very early intervals as well, just to sort of keep on top of things like that. With jaundice, that yellow coloration of the skin and sclera, that white part of the eyes now becomes yellow part of the eyes, can result in ultimately unconjugated bilirubin, which is the bad stuff. Boo. Boo. All right, that's supposed to be boo. All right, unconjugated bilirubin is neurotoxic. That's what we just talked about on that last slide, and can lead to death in some kids and neurological issues if they're not treated. So that's why we have different levels of care. We have exchange transfusions where we're taking blood out and putting in an exchange of something that doesn't have as much bilirubin in it. So we're taking out the bad stuff and putting in some good stuff, whether it's albumin or saline or just normal red blood cells, right? Or we can do phototherapy, which sort of breaks it down in the bloodstream, so it helps the liver out there. Or we can give them a drug like phenobarb, which actually helps increase liver metabolism that will break it down, right? So this is all to help avoid this whole thing called kernicterus, right? And that's where it crosses the blood-brain barrier ultimately. So jaundice is a simultaneous occurrence. Because we have increased breakdown of fetal red blood cells, so those guys have a shorter lifespan and higher mass overall in the neonates. So that's working against this. So that's sort of strike one. And then the second part here is the enzyme that binds it, making it water soluble, has very low excretion by the liver, right? The liver metabolism is sort of low going on here. And that's a strike two in this situation, right? We got a couple things working against us when it comes down to the jaundice of the newborn. Like I said, this could be a premature or even a term kid that we're talking about having jaundice. So you'll see this in the NICU. I want you prepared for this in neonatal medicine because it's something that you'll see, and I just want you to have a good grasp on it and what it means. Ultimately, we just need to be watching their levels and treating appropriately. There's people that will have to have their babies undergo a double exchange transfusion, and we'll talk about that when we get there. But jaundice can be a very serious issue if left untreated. Ultimately, it's the most common condition that requires medical attention for newborns, and if it's treated, very, very little effect ultimately on the kid. About 60% of all term babies, that's over half, right, of all term babies, or all newborn babies, will have bilirubins high enough to see jaundice, right? And that's a level, hey, guess what? I repeat this value. It's almost like I think it's important for you to know. Over 6 milligrams per deciliter. So it's important that I'm just trying to give you a benchmark so you're aware of it out there. It's very common. You'll see it in a lot of the kids that you'll be taking care of in neonatal medicine. 80% of preterm kids. So look at this. Almost 80%, if not more, of preterm babies, especially because now we're using delayed cord clamping or stripping the cord in preterm babies to reduce. Do you guys remember the fancy term? Reduce brain bleeds. What's the fancy term for that? Intraventricular hemorrhage, right? So we're trying to get all that extra blood volume into baby. That's going to help reduce brain bleeds. And so therefore, they're going to have more red blood cells to break down. Well, they're going to be more prone to jaundice because do you think their liver metabolism is doing stellar if they're preterm? I would say that their liver metabolism isn't quite on board with breaking down all those red blood cells yet, right? They're not designed to come out yet, right? They're not supposed to be out yet. So we're going to have a higher rate of jaundice, like I said, 80% compared to 60% in your preterm babies. And so more than likely, almost all the kids you're taking care of as of recording this are going to have some form of jaundice in a neonatal intensive care unit. Most of them will, right? That's 80%. That's using those statistics. All right, so the serum bilirubin levels. So these are things that can increase the serum bilirubin levels and then things that can decrease the serum bilirubin levels. So when we're looking at delayed cord clamping, remember the baby's getting extra red blood cells, and that's going to be helpful in the long run, right? What are a risk versus benefit of any different situation? What are the risks and benefits of doing a blood gas? What are the risks and benefits of adding airway clearance therapy to a patient, right? So in this situation, what are the risks and benefits of a delayed cord clamping? Well, as we talked about before, delayed cord clamping, the benefits are going to be a 50% reduction in brain bleeds and amongst other things, right? They get more stem cells, things like that. So there's more benefit than there is risk, especially if we're watching their bilirubin levels, especially if we're following up with these babies and watching them closely. So delayed cord clamping, a 33% increase in blood volume. That's going to be helpful to especially those preterm kids. So of course that's going to factor into it. Low birth weight and prematurity, we just talked about that. With their liver, the strike 1 and strike 2, put those in there as well. A diabetic mother, polycythemia, we talked about that as well. Diabetic mother, remember we're talking about LGA babies, increased blood volume. And cellular mass with breakdown, that's going to have increased red blood cells as well as increased red blood cell destruction, which would then cause an increased chance of high bilirubin. Biliary obstruction, of course, if the liver has an issue, the liver and the spleen has an issue, or anything in the GI has an issue there, it would decrease the liver's ability to conjugate that bilirubin. And of course, here's another one that I would pay attention to as well as infection. It can be a sign of infection because the baby's system is going through a massive stress, and that can actually cause it as well. Things that will decrease it, and they're very good about this in neonatal medicine. As early as we can start feedings on those babies, the better. The earlier we can start those feedings, the better. And sometimes it's doing a milk bank, right? Donated milk for the baby early on, and that can easily factor in and help those babies start to decrease that level. They're going to increase their metabolism. They're going to increase their liver metabolism. That's going to help conjugate more bilirubin, especially if their feedings include liquids, which at this stage do, right? The water content. Remember, dehydration is bad. These are water soluble, so they need hydration. They need adequate hydration if they're going to conjugate bilirubin. So early feedings has a couple of benefits to it here. Maternal cigarette smoking. This is going to be a controversial issue here. As well as vitamin E, and this is something that we'll give to those babies as well. Vitamin E. Maternal cigarette smoking and the bilirubin levels are going to be something that we're going to see out there as a controversial on how much or the physiology behind it. So we're not going to talk too much about it. I'm not going to have you guys go in detail on that part, but I want you to just sort of be aware of things that can increase serum bilirubin levels or decrease it. I know I talked about cigarette smoking increasing the chance because the baby has hypoxemia and therefore producing more red blood cells. But in this situation, maternal cigarette smoking can cause decreased baby's blood volume. So we're looking at this equaling a SGA baby, a small for gestational age baby. Therefore, there's less red blood cells to destroy or to break down RBC, right? So small for gestational age. Less red blood cells to destroy, and therefore less chance of bilirubin. So that's the idea behind the maternal cigarette smoking, is the baby's going to be small for their gestational age and usually IUGR, intrauterine growth restriction, and because they're IUGR SGA, they'll have less red blood cells and therefore less excessive destruction that would cause an increased bili level. So that's the whole thought behind it. So you're well aware of both cigarette smoking, how maternal cigarette smoking, how it can affect the baby as far as the serum bilirubin levels in one direction, as well as if the baby's hypoxic, if it goes to the level of low PaO2 being delivered to the baby, then the baby can then compensate by increasing red blood cells and so on and so forth. So you sort of see the controversy behind both sides. I've now informed you. I'm not going to make the decision for you. You can do your own research on that one. But now you're aware of both sides of that coin. All right, jaundice. There is this long, have fun saying this. It's probably the longest word I've ever typed out. They call it UDPGT. UDPGT is low at birth, and so this thing here is something that our body produces, but it's very low at birth. And as we get older, especially just in 8 weeks, first 8 weeks of birth, that value is going to go up, and that's going to help ultimately avoid jaundice in all of us. So that's the one that you want to keep going ultimately. So when we're looking at this, treatment options for jaundice, and that's what we were previewing before, so I may have spoiled it, but treatment options include phototherapy, which breaks down the bilirubin in the bloodstream ultimately. So we're using the skin to then transfer light, I think it's like a photo breakdown, and break down the unconjugated bilirubin into a form of conjugated bilirubin, so where the body can excrete it. Very, very minimal, and it breaks it down in the blood. It's very, very minimal, and it works very well. When we're looking at pharmacological treatment, the whole reason for this first bullet point up here, that pharmacological treatment, is ultimately what we're doing here. We're giving these medicines that ultimately help increase UDPGT activity. So the whole idea here is to increase this, right? Increase that UDPGT activity, and that would help conjugate more bilirubin so we don't have as high levels in the baby's system. Drugs in this category, phenobarbital, I already talked about that one. You also have dexamethasone or Decadron, which is a steroid that reduces inflammation and helps as well. There's clofarbate, and we'll talk about that, I think, in the next slide, or in the when we start talking about the drugs. So the phototherapy and pharmacology treatments are going to be very, very helpful, and you will see that used out there. Now, if a kid's very severe, they might use phototherapy plus pharmacology, or they might use phototherapy plus an exchange transfusion, right? So the exchange transfusion, very basically, is going to be taking that blood out, that bad bilirubin out of their system, and then just replacing it. And that's the whole idea, is we'll take like 5 to 20 mLs of blood out. So I'll just write it down. 5 to 20 mLs of blood out of their system, and then at a time, and then we're ultimately going to replace 85% of their blood volume. Isn't that crazy? And then if you're curious, so like, how do we know like how much to take out at a time? So 5 to 20% or 85% of their blood volume. Well, if their blood volume is normally, what's a normal blood volume is, in other words, a normal blood volume for a baby is 80 milliliters per kilogram. Oh heavens, let me go to yellow. Per kilogram. So 80 milliliters per kilogram is ultimately what we're looking at here. So that way we can sort of figure out how much blood volume does this baby have. So if this baby is only 1 kilo, we might go on the lower end of the exchange transfusion, right? If this baby is 5 kilos, oh heavens, then we might go on the higher end of the mLs, right? So we need to ultimately exchange 85% of their blood volume. So that's how we sort of figure out 80 mils per kilo, sort of gives us a rough area of how much to look at doing with each one of these. So replacing that bad, unconjugated, toxic bloodstream, or that blood that's in their blood vessels, with the good stuff. So like I said, we'll use albumin, we'll use normal red blood cells, right? And we'll talk about that in that slide further. So phototherapy, this is the cutest of all the therapies. That's my personal opinion. Yours may vary. This one's pretty straightforward. We're just going to use blue lights, and the blue lights will break down bilirubin into, guess what? Water soluble, so that way it can be excreted in the bile and the urine, so they can get rid of it naturally, right? And you can sort of see that yellow tint that's going on over here, and you see this baby turn a normal-ish color afterwards, right? So that's what you're looking at here. It just helps break that down. And they've been using this for years. They will even tell parents that take their kids home that have this, to take the kid outside for a couple minutes here and there, or, as long as it's not long enough to burn their skin or anything like that. So something that's pretty inert. Big thing that we have to watch out for, especially in our premature kids with phototherapy, is water loss. We talked about that. It can heat up the baby, so that's heat stress that we have to worry about. So remember, we talked about that in the previous presentation. Heat stress is not a good thing. Cold stress is not a good thing. So you don't want heat stress. It vasodilates. It can drop their blood pressure. So if you have a premature kid and they get hot and their blood pressure is already low to begin with, it can actually cause their blood pressure to get even lower. And we're looking at maybe a cardiovascular collapse at that point, right? Pretty significant. So we need to watch these babies' temperatures, as well as make sure nothing gets into the eyes. And you'll see we put these like cute little, pretty much this foam thing over their eyes to protect their eyes while they're on phototherapy. It's adorable. All right, so this is what they look at. There's different types of bilirubin light therapy. Generally, it's harmless. There's very few side effects. Like I said, the big thing you have to worry about more is just protecting their eyes and make sure they don't get heat stress with it. So protect eyes, monitor their fluid balance, right? You don't want them to get dehydrated, because dehydration would actually work against you here, because it's water soluble. If we're dehydrated, they're not going to conjugate that bilirubin. Oh heavens. So they have Billy lights, where we just shine these lights on the baby, and you can see this baby has, here, let me go to yellow. It's appropriate. You can see the baby has sort of those sunglasses going on there, and it just sort of shines on those little guys. And we have these little lights over the isolettes that will do that as well. They even have Billy blankets, which is that picture you're seeing over here, is that Billy blanket that mom is holding that baby with there, a little kangaroo care skin to skin. And this is one of your things you have to watch out on your late preterm babies as well, right? Those kids that are like 34 to 36.9 days, or 36.6 days. 36.7 would be 37 weeks. So when we're looking at these babies, they're usually either like bilirubin, blood glucose, and temperature, right? Those are some of the big things these kids are looking at here. So phototherapy, like I said, pretty harmless. We just got to watch out for protecting their eyes, monitor their fluid levels, make sure they're getting plenty of wet diapers, and go from there. The exchange transfusion, I already talked about this a little bit. This is we're going to do usually 2-volume exchanges where they do this twice. So if you hear the terms double exchange, this is exactly what they're talking about. So exchange transfusion means we're going to take blood out and replace it. Okay, so we're going to take the toxic blood out of their system, not all of it, right? We're not going to completely do a system flush, right? We're not flushing a radiator in a car or anything like that, right? So we're going to take out some of the blood. Remember how much we're going to remove? Well, before we get that, let's do this. So two volume exchange is very, very common. Blood volume is estimated by weight, and we said that that was normally how many mils per kilogram? I hear you all screaming. Some of you aren't, and that makes me worried. 80 mils per kilogram. That's how we sort of estimate how much blood volume when we're doing this. So we do it maybe around twice. We're just doing a small volume exchange here and there, and that should ultimately help us. We're removing how many milliliters of blood? Hopefully you remember. Sounds like I might ask you this in the future, especially if I'm making a big deal about it here. So 5 to 20 mLs of blood is ultimately what we're going to do to replace with whole blood is one of the options, but we can also replace it with normal saline. We can also replace it with plasma. Great. And then, or we can also replace it with something called albumin. Nice. So with those other options, so whole blood is a good method, but if the care team sees more advantage doing it with normal saline or plasma or albumin, those can be used alternatively. All right, so this process is repeated slowly until approximately what percent has been replaced? What percent? You guys remember? Some of you are like, I don't, and I wasn't writing it down. Shame. All right, 85% of their blood volume has been replaced. And that's the goal, is to ultimately replace 85% of their blood volume. That helps get all that toxic stuff out of their system and replace it with good stuff, whether it's whole blood, normal saline, albumin, or plasma. Whatever it is, let's replace it with something that's not toxic, right? Whatever is most adventitious. This kid has a high crit, so on and so forth. We might use something like normal saline, especially if they're dehydrated for some reason. Let's say they're under phototherapy lights and they're dehydrated, they have hardly any wet diapers. Normal saline sounds like a good option here. Plasma, especially if the baby has low platelets. Let's say mom had HELLP syndrome. Remember the whole preeclampsia thing and HELLP syndrome? Hopefully you do. I'm trying to connect dots for you here. If HELLP syndrome, remember LP is low platelets with HELLP syndrome, HELLP. So hemolysis, elevated liver enzymes, and low platelets, right? You should have that down, right? You should remember what HELLP syndrome is. And then that low platelets, well, what's in plasma? Platelets, right? So this could easily be, and we can give just platelets if we wanted to, but plasma also has platelets in it. So maybe platelets are a good option for that kid. So we just have some options here. So hopefully you get exchange transfusion, double exchange transfusion. It's not something done as a first line against a elevated jaundice level. An elevated jaundice level, the first line treatment's going to be phototherapy, and then if it's really high, then they're going to do a combination, whether it's phototherapy and exchange transfusion, or phototherapy and pharmacological intervention, right? It's going to be what's ultimately best for that kid when they decide what to add to it. So remember in advanced pharmacology, you talked about how if someone had really bad blood pressure, really high blood pressure, hypertension, not only would they give them a drug for hypertension, but they would also add in another drug for hypertension. So if they're on a calcium channel blocker, they could either increase the dose or they can add an ACE inhibitor, right? So this is sort of that same thing. We're already on phototherapy lights, and now we can add something from a different category to help control it, so that way we don't have something like kernicterus. All right, pharmacological treatment. So this is another option we already talked about, phenobarb. This is a barbiturate. Hopefully you remember that from back in advanced pharmacology class. This one's neuroprotective. So do you see advantage in using this? I hope you do. And this one increases the liver metabolism. Right, the liver metabolism, which would then increase conjugation, which would then decrease the bilirubin levels. Hey, what do you know? Dexamethasone is a systemic steroid that reduces inflammation, right? And so when we're looking at this, this is a steroid that A, we could have given to mom, but B, we can also give to baby when it comes down to the treatment of their bilirubin levels too. So this is something they might hold off on a little bit. There are some studies out there that show giving steroids to newborns have led to developmental delays. So they usually tend not to pull the card on steroids. It's sort of a controversial issue because it depends how you look at the study. With the kids that survived, because they got the steroids, they were in such a sick state to begin with. Did they have developmental delays because they waited so long to give it, right? This is where there's a whole debate about that topic. This is not the PowerPoint to talk about that, but I'm just saying they're not as likely to use steroids aggressively in this population. Now, I'll give it to mom for lung development. That's great, and that hasn't been shown to have developmental delays. It's the developmental delays that are given to baby after birth that's been associated with it. Okay. So dexamethasone reduces inflammation. That should help reduce red blood cell production, right? Remember, as an inflammatory response, you're going to release cytokines. You're going to release a bunch of stuff to help go repair and nourish stuff. So that's going to help with that as well. Clofarbate reduces hyperbilirubinemia in conjunction with phototherapy. So that's another drug you might see out there. And finally, albumin. Hey, that's one of the things that can be used for an exchange transfusion. What do you know that I would have that in there? In both. Bilirubin and albumin bind and improves delivery to the liver for conjugation, so it ultimately helps. So as you can see, it actually might be advantage and partially pharmacological treatment to do an exchange transfusion with albumin if a baby is deemed appropriate for it. All right, so I'm not going to have you guys memorize this chart or anything like that. I just want you to sort of understand their levels of care for phototherapy. So if we have a term baby and their bilirubin levels are anywhere between 17 and 22, they're just going to do phototherapy lights, break it down naturally. If that's not working, or if those levels climb, like if it's working but their levels still climb, right? And now where they're at 25 to 29, that's pretty high. Now they're going to trigger the exchange transfusion in that sort of patient population. So I'm just trying to get to you here familiarity with sort of, we're going to start with phototherapy in general, right? So super sick kids, we're going to have a lower threshold because their body's not going to be able to compensate. They're going to have more of a chance for it having effect in their system. Less than 1,500 grams, of course, we're going to have an even tighter leash on pulling the exchange transfusion card, right? So I just want you sort of familiar that the smaller or the more sick the baby is, the earlier on we're probably going to pull the exchange transfusion card out. Yes? Yes? Everyone get that bullet point? Okay. All right, kernicterus, we already talked about this. This is where it crosses the blood-brain barrier. So high levels of unconjugated bilirubin will cause the bilirubin to attach to the brain cells, right? And this is after it crosses the blood-brain barrier. So this is everything I was saying previously. Ultimately, what we see if a kid goes into kernicterus, and these kids have just like the screeching cries, it's very bad. It results in their motor function being impaired. It can lead to cerebral palsy, hearing loss. There's a whole bunch of neurological and developmental issues that go along with kernicterus. And so that's one of the reasons why we do everything we can to avoid this kid from crossing into the blood-brain barrier, to avoid that bilirubin from really crossing over into that area. So that's something that we have to watch. And like I said, it can even lead to seizures and coma and all that other stuff as well. But we need to watch this, we need to treat, and that's why it's important that they go to their follow-up pediatrician's appointments. That's why we follow it closely in the NICU. And now you're aware of it as well. So what level can kernicterus occur? Oh heavens. So in a newborn, preterm and severe preterm kids, they're going to sort of have different levels. So level over 20 in per 100 ml. So this is like 20 volumes percent. If you guys remember that from way back in the day, only it was grams per 100 mLs. So this is milligrams. So levels over 20 milligrams per 100 mLs in a term kid could lead to kernicterus ultimately. When we're looking at preterm, of course, this value is going to get smaller. Do you guys see a pattern here? They're more prone to kernicterus the smaller they are. Preterm kids, look at that point there, 10 milligrams per 100, more prone to crossing that blood-brain barrier. So we got to be very aggressive. The smaller the baby is, the more preterm the baby is, the more aggressive our therapeutic interventions are going to be to prevent kernicterus. It can even occur, right? Here's where, see this point here, you're like, levels below 3.3. In some babies, it can occur even in levels below 3.3 milligrams. It's been documented that it can occur there. So this is a very serious issue. That's why I bring it up here. Is it necessarily specific to the respiratory system? No, but you're going to be a very valuable member of the NICU team, and I want you to understand what's going on, why they're doing an exchange transfusion, why they're giving this baby albumin, why they're so on and so forth, right? Preparing you for the future. Normal value. So now we're into just the regular lab value. So I'm off of the jaundice thing. So expect jaundice to be a big part of your next exam. Understanding it, I just want you to be very knowledgeable about that whole process because it is one of the most common things that you will be seeing out there. Normal values for babies, 16 to 19 grams percent for hemoglobin, 50 to 60% for crit. Now that will drop as the kid gets older, but this is just a newborn, right? Thrombocytes, 100,000 to 350,000, pretty straightforward, as well as leukocytes, around 9,000 to 30,000 when we're looking at it. So in utero, so when the baby's inside, a low PaO2, and we talked about this already before, a low PaO2 will stimulate the baby to produce red blood cells. This is exactly what we see with people that have chronic hypoxemia, with chronic bronchitis or emphysema, right? Their body produces more red blood cells that become polycythemic. It's a way for them to carry oxygen and still get oxygen to their brain, their kidneys, their liver, so on and so forth. So what happens here with these babies that have low PaO2 in utero, they'll ultimately come out with a high H&H, right? And that's something you'll see there. Well, let me ask you this. What does a very high H&H mean to the viscosity of the blood? And what does the viscosity of the blood have to do with cardiac function? In other words, how hard is that thick blood going to stress the heart? Is it going to be very easy and smooth for the heart to squeeze it, or is it going to cause more effort or oxygen consumption of the heart muscle to squeeze that blood, right? It's going to cause more stress and consumption. So there are downstream effects of this as well. It's not all positives. So after birth, when the baby has an increase in P little AO2, so that's in their artery, right? This will ultimately decrease the production of red blood cells in their system, and that's why you won't see jaundice for like maybe 8 to 24 hours or something like that. So it's going to be a little bit before it, once that PO2 goes up, that's when you might start seeing it. Anemia in a baby is a hemoglobin level less than 13 grams percent. A hemoglobin level less than 13 grams percent. And a lot of this is going to be caused by hemolysis, especially if the mom had HELLP syndrome, right? What's the H stand for in HELLP? Hemolysis, right? Right? That's what we're looking at here. So hemolysis, and hemolysis can be caused by Rh incompatibility and ABO incompatibility, as well as infection, right? So that's something that we have to watch out for. If we know there wasn't an Rh incompatibility or an ABO incompatibility, then that's something that we have to look at. Is there a possibility this baby has an infection going on? So let's say we draw a CBC, and we see a lot of immature white blood cells compared to mature white blood cells, and we see anemia. Those are all pointing towards a likelihood of an infection, especially if the baby's has, let's just say they were a premature rupture of membranes, right? All those are pointing towards the probability of an infection on that kid. I do have information in your Blackboard about RH incompatibility and ABO incompatibility. I won't go into them here because I don't want this presentation being too long, but please check those out, something you might want to be familiar with. Polycythemia, this is the big one, hemoglobin level above 23 grams percent. Or if they're doing a venous crit, 65%. That's huge, right? So this can be because there was a maternal fetal transfusion or twin-to-twin transfusion. Twin-to-twin transfusion, I think we already talked about a little bit. That's where you have twins in utero, and then they're both sharing a placenta. And then they're both sharing a placenta, and one twin over here got hardly any of the nutrition. The other twin over here took all of the nutrition. So we have a twin-to-twin transfusion. In other words, this one over here, this bigger twin, took most of the blood and most of the nutrients. And that's why they're larger and one's small. So it's called twin-to-twin transfusion syndrome. So the twin that's bigger, obviously, is going to have a higher hemoglobin level, right? Delayed cord clamping, of course. Delayed cord clamping is what we've already talked about, how it improves and increases the blood volume by 33%. This is very good, especially for kids that were worried about becoming hypoxemic, especially if there was a traumatic delivery or they're preterm, and they're going to have low surface area in their lungs because they're only in their canicular stage, right? So we got to watch out for that. So delayed cord clamping is actually going to help you as the respiratory therapist oxygenate that baby with lower FiO2s and lower pressures from the ventilator because their blood's more optimized for carrying oxygen. Isn't that cool? Intrauterine hypoxemia, we talked about this. If the baby's somehow stressed in there with a low hypoxemic, just like your COPDs patients, they're going to increase their red blood cell production as a compensatory mechanism, and that's when you might see polycythemia on these newborns. Thrombocytes, they obviously help with coagulation process. So this is going to be something that we need to pay attention to because there's something called thrombocytopenia. That's where the platelets are less than 100,000. So this is associated with, guess what? Infection, right? That's the big thing here. So if we're looking at an infection, that's going to be something that could be a sign that this baby might be going into sepsis. They might have a torch infection, and that's something that we have to look out for as well, especially when we're looking at things like thiazide diuretics can also cause it. And hopefully you remember thiazide diuretics from advanced pharmacology. So that one I'm not going to go into in detail because you should have covered thiazide diuretics in advanced pharm. So when we're looking at torch infection, it's toxoplasmosis, rutabaga, cytomegalovirus, and herpes, I believe. And we'll talk about that in the infections PowerPoints more. But a torch infection is something we have to watch out for. And so if we see thrombocytopenia, in other words, low platelets, that could be a sign of sepsis, a torch infection, or thiazide diuretics. So, what's the big deal with thrombocytopenia? Obviously, that's something that we need in our bodies, and it can cause bruising, right? We'll see these petechiae form on the skin, right? That's what you're looking at here, and then it can ultimately cause, yeah, that's not good, an intraventricular hemorrhage. Remember, the more preterm a baby is, the more prone they are to a brain bleed, and that's what you're looking at with the possibility with thrombocytopenia. We need to watch these kids because they're a higher chance for a brain bleed. So if mom had low platelets with HELLP syndrome, we might need to give baby platelets so that way they don't have thrombocytopenia, that way that we can reduce the risk of an IVH, right? That's why delayed cord clamping reduced brain bleeds so much. That's why it reduced IVH so much, is it helped give them more thrombocytes. It helped give them more vascular volume. We talked about that sort of internal CPAP that it gives, right? And it helps them ultimately avoid that brain bleed situation in a couple of different ways. So the big thing here would be to get these babies platelets or thrombocytes or whole blood, right? Things that have these in them. So DIC, tell me about DIC. Well, DIC is disseminated intravascular coagulation. In other words, this is something that a baby can go into. And I've seen mom go into it at deliveries as well. Like I said, I'm not here to scare you from all things labor and delivery. I'm just here to prepare you if you do see a DSC situation. DSC in a neonate is usually caused by infections and mostly a gram-negative infection, like a gram-negative sepsis that's going on. It's pretty significant there. And so what happens with DIC is plasma and a bunch of other stuff are going to leak into the skin. That's why you've seen those petechiae on that previous slide. That's why you've seen that hemorrhaging in there. So here's the situation. Look at this point here. You're going to treat DIC with either heparin, which thins out blood, or platelets, which stops bleeding. How do you decide which one to use? Talk amongst yourself, right? How do you decide which one to use? Well, the heparin, if there's a bunch of clots, if you don't see bruising, I'll repeat that again. If you don't see bruising, you don't see petechiae, this patient's going into DIC, it's more of a dead space issue, like PEs pretty much, then that's when you'd want to give heparin to break up those clots, right? That's what we're looking at here, coagulation. The platelet transfusion is if you do see lots of bruising, right? You have massive bruising under the skin, everything's just sort of weeping and leaking out of the capillaries. That's when the platelets are going to help that patient. So we're going to look for bruising or no bruising, right? We're going to look for those signs. What do we have here? More of an issue with clots or more of an issue with leaking, capillary leaking? That's what we need to look at. Leukocytes. Neutrophils are going to be our most prominent, and there should be around 11,000 in these babies. So this is where we talk about immature to mature white blood cells. So our bands is going to be immature neutrophils. Our segments is going to be mature. Now, ultimately, you and I and babies should have more segments compared to bands. So segments are like your starters on a varsity team of some sort, right? The varsity chess team, whatever it is, right? These are your starters. These are your primary players. They go out, they do the job, they're very good at it. And then the bands are the people that are like JV, right? They're in the wings. They can do a little bit, but they're not ready yet, right? They don't have the same talent at mastery yet, and so they're not really there yet. So what does this mean? Why do we care about looking at the ratio between segments and bands? Well, if I have more immature neutrophils than I have mature, right? So for some reason, this becomes a different ratio where I have more immature than mature. That's a sign of infection because that means all my mature ones have gone out to war, right? They've gone out to go eat whatever bad things are out there. And therefore, that's a sign that this kid could be battling an infection because all the mature ones are low, right? We have very low reserves of the mature and we have more immature, which are the bands. So we'll talk about it being left shifted. We're not talking about the oxyhemoglobin dissociation curve in that aspect, right? We're talking about a left shift. In other words, is there more immature bands, immature white blood cells? Is there more bands than there is mature, which would be segments? So if they talk about a baby being left shifted or they have more immature white blood cells, that's a possible sign that could be that kid might have an infection going on. So they might have to culture, do a sputum or trigasmate, as well as culture lines, things like that. Neutropenia. All right, neutropenia means what? A low white blood cell, right? Neutropenia is low white blood cell. So within the first 60 hours of life, if it's under 7,800, then obviously that's neutropenia. After the first 60 hours, then if it's under 1,750, right, even lower. So please note this. Please note this. Please note this. Yeah, I repeated that 3 times on purpose. You might want to remember this point here. The most useful indicator of an infection in the neonate is overall neutropenia. right? The most useful indicator of infection in the neonate. So I might say, hey, their bilirubin levels are high, right? That could be a sign of infection. Their red blood cells are high. That could be a sign, right? So all this other stuff I could talk about, but you're going to be like, nope, I remember Derek specifically saying the most useful indicator of infection in the neonate would be neutropenia, and you would be correct, and you will thank yourself for remembering that. All right, let's talk about sugar. Sweet. Fetal glucose, so that's in utero, are directly related to mom's levels. So that's why if mom has either gestational or pre-gestational diabetes going on, we just have to watch that baby afterwards because they're going to be producing a lot of insulin. And when that baby comes out, their blood sugars might fall rapidly because they're producing so much insulin. So glycogen stores are already present in the 9th week of gestation. It's pretty early on. And at birth, they're 3 times more than the adult level. That's a lot, but they're going to need it because they need that energy initially, especially if it takes a while for them to breastfeed or get some food into their system. So normal serum glucose for these babies is roughly around 70 milligrams. Hypoglycemia is where it's less than 35 milligrams or 25 in preterm kids, right? We're looking at smaller levels for those preterm kids because they don't have brown fat, so on and so forth. So if those levels are low, that's considered hypoglycemia. So how would you treat hypoglycemia? Well, that's through D10, right? That's where we give them sugar. Right, hypoglycemia causes, we already talked about this, hyperinsulinism, and this is usually a result of gestational diabetes or pre-gestational diabetes. And so the baby comes out, they look great, they're looking good, but 2 hours later they're looking sort of depressed and flat and not as energetic. That's that hypoglycemia because their body's producing a lot of insulin. That's why we try to get those babies to eat early on too, feed as soon as they can. Prematurity, we already talked about that one. IUGR, intrauterine growth restriction, we already talked about that. They don't have the stores of energy because they were restricted in their growth. Same thing, prematurity, they don't have the stores of energy because they don't have brown fat, things like that. Sepsis, of course, their body's going through a massive infection. Shock, usually because of sepsis in a lot of cases here, unless they're in heat stress or cold stress or something. Asphyxia, of course, that's going to cause hypoglycemia because of the shivering. Sorry, asphyxia, not hypothermia. Asphyxia, of course, is going to cause hypoglycemia because there was no oxygen being delivered to the tissues. Then you're looking at the Krebs cycle and all that business. Hypothermia, that's the one where my brain was at earlier, is where the body's super, super cold and they're going to shiver as a response, or they're going to try to accumulate as a response. They're going to burn through as much sugar as they can. So if a baby's cold, they're burning through sugar. Even if they're not shivering, their body is using more of a metabolic process to stay going. And finally, adrenal insufficiency if their kidneys aren't working well. All right, signs of hypoglycemia. So this is, I think, almost as important, if not more important, because this means you can then recognize, hey, something's going on, and you're alerting the care team. Hey, I seen this baby tremoring, like they had a ton of albuterol. I didn't give them a continuous neb, but they looked like they had one, right? If the baby's irritable, now take that with a grain of salt, right? They're babies, they can get irritable, just at baseline. So that's something that you would look at in combination with other things. Cyanosis, right? The baby's body's starting to shut down, hypoglycemic, they start to become apneic, or they start to breathe super, super fast. That's because they're becoming acidotic, right? And it's telling their brain, their central chemoreceptors, to breathe faster, right? So that's their body compensating. So if they start to work really hard to breathe or shut down altogether, that's a sign that they're in that acidosis. So their body's either going to shut down as a response, that dive reflex, or do its natural term thing. So more in your term kids is when you would see the tachypnea. In the term kids, you would see the tachypnea. Preterm kids, you'd see them go apneic because they're supposed to just rely on mom's system as their life support. Kids vomiting, babies vomiting, I should say, seizures, the baby's lethargic, they're just floppy, they're not really working with you, they're not eating anything, oh, just a weak, wimpy cry. That's why a strong cry is a very reassuring thing in the NICU world. I remember there was a neighbor baby to our daughter and had super strong cry, and I remember hearing the family of that baby complain about how strong that cry or how loud that cry was. And I'm like, at least your kid has enough energy to cry, right? Sort of a sad thing. Hopefully that didn't make you sad, but I'm like, count your blessings, right? So weak cry is a bad thing. And then hypothermia, we talked about that. The baby going through a bunch of energy and now they don't have the energy to compensate and now they're cold. So what do we do for hypoglycemia, not to hypoglycemia, but for hypoglycemia? D10. So this is not something the RT would be giving, but I want you just to sort of be, hey, did you guys give D10? Or if you see it on the medication record or anything like that, I want you sort of aware of why they would use that and how to employ that. So that's what they would use, is they'd give the baby some D10. So they can either give it in an IV, it's just sort of a continuous, 4 milligrams per kilo per minute, or 200 milligram bolus over 1 to 3 minutes. It just depends how severe it is. If it's starting to trend lower, maybe they do the IV. If it's pretty low, then they might just go ahead and do that bolus. Now, I understand these can change, but I'm just giving you guys a rough view of 2 different strategies that they use for hypoglycemia, especially if the kid is not feeding yet. Immunoglobulins, these are things that we'll look at. I'm not going to go into detail here. I think I do have a resource, IVIG resource for you guys. And these are different immunoglobulins that we'll look at and make sure these kids have good levels at. If a baby has very poor immunoglobulin levels, we can give them IV immunoglobulins as well. Right, and so that's going to help boost these kids' abilities to fight off things like infections, things like that. So I'm not going to go heavy on the immunoglobulins. I used to go through all these. What does IgA do? What does IgD? What does IgE? What does IgG? What does IgM? What do all those do? And then I had a lot of students that thought that was too much information, but understand what immunoglobulins are, and then if they're low, what would we do? Okay, that's where I'll go there. If you want to go deeper, I'll try to put a resource in Blackboard. If not, I believe your book actually does talk about this as well. ABGs, whew, we made it to ABGs. So ABGs, this is the most, here, what? The most reliable index of oxygenation and ventilation and acid-base balance. So what are some indications? So we're not talking about a pulse ox. We're not talking about a cap gas. We're not talking about a VBG from an umbilical venous line. We're talking about an arterial blood gas. Now this can be through the umbilical umbilical artery line. Right, and hopefully you've looked at the policy or looked at what an umbilical artery line is or does. So it can be drawn off the umbilical artery line, or it can be drawn from a radial artery, just like your normal ABG, only this one's done at an almost flat angle with a butterfly needle. It's pretty crazy. Usually, especially if they're really premature, we can use that phototherapy light, put it under the wrist, and you can actually see the radial artery. It's very interesting stuff. So what are some indications? We'll get off that point. What are some indications for an ABG? The baby's working hard to breathe. They have a high Silverman-Anderson index. Hey, there's me bringing a blast from the past. Working hard to breathe, so nasal flaring, retractions, grunting, things like that. Clinical changes, especially like vent setting changes, right? Signs and symptoms like they're becoming more floppy, they're becoming more tachypnic, they're having more apneas and bradycardia. So let me talk about that for a second. There's A's, B's, and D's, and this is something we talk about in NICU reporting. So you know how we talk about like this patient gets this medicine, BID, and this one QID, and you know how we're giving a report about a patient to the oncoming therapist. Well, this is something that we used to talk about a lot, is A, B's, and D's. So A is for apneas. How many apneas this baby had? B is for bradycardias, and D is desaturation. So the more A's, B's, and D's a kid has, usually the more sick they are, or more interventions that they need. And so that's something to sort of pay attention to there. So if a kid's starting to get more A's, B's, and D's, then they might want to grab a blood gas of some sort. 15 to 20 minutes after vent setting changes, just like the adult world. And then once they're set up on a ventilator, they'll get either a cap gas or anything like that as well. So what are some sites for ABGs on a neonate? Umbilical artery is going to be the most preferred method because you don't have to poke anything. The umbilical artery catheter is already there. As long as it's in correct position, you don't have blanching of the lower extremities, things like that, you should be good to go. The brachial artery is difficult in neonates, so you probably won't see that one. Radial artery would be your next preferred site after the umbilical artery. So that's where we would go there if we need to before they put in a UAC, or if the UAC is only in for like 7 days or something like that. The UAC gets pulled, then we'll just have to go radial artery. The heel gas, this is a capillary blood gas, or a CBG, right? Capillary blood gas, right? This is a mixed sample, so when we get a CBG, it will tell us about pH and CO2 pretty reliably, but it won't give us good information about O2. Will it give us an oxygen value? Yes, it will give us an oxygen value, but remember, we had to heat up that site to quote-unquote arterialize it. So we had to heat up that site, which increased oxygen consumption, which would then decrease the PO2 value on the blood gas, on the capillary blood gas. So is it reliable to look at oxygen on a capillary blood gas? Is it a good value that you should use to trend everything? No. So if they ask you to look at oxygenation from a capillary blood gas, you would inquire on their thoughts of getting an arterial blood gas, right? An arterial blood gas, either from the radial artery or if they have an umbilical artery line from that one. All right, so cap gas will tell us about pH and CO2. This is fine. If all we're looking at is ventilation, let's say they're on a ventilator and we want to see that they have a good pH and good CO2 level, then a capillary blood gas is perfect. It'll work great. It's just not going to be reliable with oxygenation. So different monitors that we have, blood samples. This is the radial line, of course, just like you have with your adults. It's going to be towards that thumb side there. Axillary artery, this is just sort of showing different locations around the baby. Obviously, femoral is not a location I would recommend, or pedis. So usually the most common site I've seen was the umbilical artery or the radial artery. Those are the ones I want you to be concerned about, right? Umbilical or radial artery site. Capillary samples, and we have some to play with in the lab, so hopefully we'll get some lab time soon. Indications, we need a gas, but we don't have arterial access, and we don't want to poke them. So this is non-invasive monitoring. If it's abnormal, in other words, their pulse ox, or if their end-tidal CO2, if anything like that is looking a little odd, then we can sort of see just if anything's causing changes in their pH or their CO2 levels. So any changes in therapy, like they're on a ventilator and we just don't want to poke them or draw more crazy amounts of blood from them, we can do a cap gas. Because cap gas, not going to use a lot of blood for it. And we're going to just take a little, heat up their heel. You're not going to milk it, but you're going to heat it up and then do a little lancet on the side of it. You never want to go in the dead center of a heel. And I think I have a picture of that coming up soon, but and then we'll just do like a little drop of blood and it'll tell us pH and CO2. It'll give us an O2, but like I said, do not trust the O2 on a cap gas. And this is the puncture sites, right? You either want to do the outside of the heel or the inside of the heel. We can also do them on the fingers as well. And they're the little lancets, just like they use for blood glucose. You're not there to sort of milk and mix blood. You just want a good back pressure to get that blood drop to come out, but you're not there to mix blood and pull it out. So equipment for a CBG, we need to warm them up, so you can use a damp cloth. We've used this in the ER too for people that came in cold, and we'll just use a warm cloth on the hand we're putting the pulse ox on or something like that. or warmer, right? We have these little tiny little purple warmers that we'll put on the heel. Lancet, of course, the Lancet to get the blood, to go through the skin and get the blood. Place to get rid of it. Obviously, you're going to be wearing gloves. Alcohol wipes, of course, sterile gauze, a bandage, obviously, because you're doing this. Eye splash and shield, yeah, that can happen. Cap tubes, that's how you're going to get the blood in there, or whatever it is to get the sample. Now, newer machines might be a little bit different. This is more the older ones. They used to have a metal flea on it that you would use back and forth to sort of mix the sample. And of course a label. And we'll either send it down to the lab or you'll run it, just depends at where you're working. So contraindications, if this baby is walking around, so you're working in a pediatric ICU and you got a kid that's, let's just say they're 12 months old, and they're like, hey, should we be doing cap samples? And you should be like, no, right? Because that's going to developmentally change how they put their foot down on the floor and walk. So that's actually going to be a big physical and occupational therapy issue. And it actually is not good for all the nerves that are in their foot too. So remember, proprioception is how they sort of get that input from their body, that afferent or afferent signal to their brain can really be affected. And so if there's a lot of pain with their heels, they're going to walk on the ball of their foot, and that's going to change a lot of their body mechanics, and it's going to set them back developmentally. So no, if there's already calluses in that area, are you supposed to go through a callus to get another sample? That sounds cruel. Please do not. If the kid has an infection in that area, if they're under 24 hours old, of course, they might not have shunts that are closed yet, things like that. We need to look at their oxygenation status. Do not get a cap gas if you would need to look at their oxygenation status. You would inquire about a possibility of an arterial blood gas. Yes, hopefully you heard me say that because it's the second time I've said it. If their blood flow to their feet is very, very poor, right? If they're coating, things like that, that's not going to be good. Or if they're polycythemic, you're going to not be able to usually collect that blood sample, right? Because their blood's thick. Complications, you can cause infections because you're puncturing the skin. Hematoma, bruising, these sound a lot very similar to your arterial blood gas complications, right? Nerve damage, of course, I already talked about proprioception, how it can change how a kid walks ultimately too. Bleeding, of course, pain, scarring, and then inappropriate management as well. Big situations, because especially inappropriate management, they're like, oh, their capillary oxygen level is low, and you're going to be like, no. No. What are your thoughts on an ABG? All right, arterial line sites. Umbilical artery is the most preferred place in a neonate. They can do a radial artery, posterior tibial, on the top of the foot. In theory, however, I would either do the umbilical line or the radial line, just like the adults. Radial line would be that second preferred site in a neonate. First preferred for an adult, of course. Adults usually don't have their umbilical site intact. I'm just saying. I haven't seen one yet, anyway. Little joke there. All right, uses. We can look at their blood pressure, and that's the most common indication for arterial line neonate through adult is actually blood pressure, continual blood pressure monitoring. So kids that have cardiac defects, congenital heart defects, kids that are septic, that have very labile blood pressures, things like that. That's going to be usually the common indication. Then they can draw gas off of it, but that's the most common indication is actually looking at hemodynamics. The waveform going to tell us about the patency of the line, the quality of the pulse pressure. Remember, the pulse pressure, I don't know if I've talked to you about this as well. The pulse pressure can actually tell us if a PDA is open or not, and then actually it can give us a calculation of mean arterial pressure as well. So the pulse pressure, why does it widen with a PDA? Well, here's your aortic arch. And then we'll do pulmonary artery. All right, and then we're going to do, here, let's do green. So why does my mean arterial pressure change? Why does my pulse pressure change? So what's pulse pressure? Well, pulse pressure is the difference between systolic over diastolic. right? It's just the difference. Now, mean arterial pressure is systolic plus diastolic times 2 over 3 because you spend twice as long in diastole, so that's why you have systolic plus diastolic times 2 over 3. So that's what mean arterial pressure is. But for pulse pressure, it's just the difference between your high and your low, right? The systolic minus dystolic, right? That's a rough look at stroke volume when it comes down to hemodynamics. Well, if this PDA is open, and we'll just do, let's do a dark red blood. So I have purple deoxygenated blood that's going into my pulmonary artery, okay? If the PDA is open, during systole, right, blood is going to be pumped from the right ventricle into the pulmonary artery, yes? During systole, when the heart is squeezing, blood will be pumped into the pulmonary artery. Well, most of this blood hopefully will go to the lungs, but will some of it come through the PDA into the aorta? Absolutely, right? So my systole increases. So here, let's do this. So with systole, I increase blood volume in my aorta. I increase blood volume, which will increase the systolic pressure. So systole increases my systolic pressure if the PDA is open. So I'd have a higher systole. So instead of 60 over 30, it would be 65, right? So I'd have a higher systole. Okay, so that was systole. Well, what about diastole, Derek, right? What's the deal with that one? So down here, we'll sort of do the same drawing as much as I can. I need to go to art school. All right, hopefully you appreciate me for trying at least. All right, during diastole, you have your highly pressurized arterial system, right? And it's back pressure. During diastole, your pulmonary semilunar is closed as well as your aortic semilunar is closed. So that means this aorta is back pressured, right? This is that low number, the diastole. So if this is closed, the path of least resistance, and there's no valves here, is actually going to be coming back through into the pulmonary artery. So that means during diastole, we're losing pressure in the arterial system, right? Because it's leaking into the pulmonary system. Remember, I said the calculation for MAP was systolic plus diastolic times 2. That's why you have twice as long of this situation, right, of the blood backing up and going into the lungs than you do of this situation where the blood gets diverted from the lungs, at least a little bit of it. So that's why you see pulmonary edema on these kids, right? You see that twice as long of this situation of adding blood volume to their pulmonary circulation. Well, what will happen to their diastole volume, or what will happen to their diastole pressure? Well, during diastole, the arterial pressure will decrease because we're losing pressure, right? Because there's a hole in the system, there's a leak, there's something that's bleeding off pressure. So when you see the pulse pressure widen, aka you see the systole go up and the diastole go down, that's a sign that their PDA is open. I'll repeat that again. When you see the systole increase and the diastole decrease, and you hear that whooshing heart murmur, whoosh, whoosh, instead of lub-dub, that's a sign that their PDA is open. And that kid, remember we talked about this, with the PDA, you got to watch out for pulmonary edema. Okay, so that was a big side channel. I hope that sort of picture between systole and diastole and why there's a gradient in between their pulse pressure, with the pulse pressure narrowing. If you see it start to narrow, that means that PDA is closing. If you see it widen, it means it's open. Now, distress can change this. If I go in and stress a kid, then it can actually close off or open up, right? It can cause that PDA to open and close. And we're not talking about permanent. The PDA can go from being open to close, open to close, open to close, just depending on where that kid is. All right, blood gas management. This is a slide. I would think that this information going out for NICU clinicals, if you make it into a tiny little reference card and put it on the back of your badge, especially if you plan on working NICU down the road, I think that would be very helpful. So this gives you normal blood gas values for a kid that's preterm, a kid that's greater than 1500, and then of course your term kids. So I would expect this, especially when we do scenarios in the lab. I would expect you to sort of understand this, because especially when we get to vent management, I might say, hey, you got this preterm kid and their pH is 7.26, and you'd be like, oh, that's acidotic, when in fact that's not. For a term kid that is, but that's not, right? So I want you to sort of look at that situation and understand what it is for preterm, bigger kid, and of course of a term kid. So this bigger kid here, this greater than 1500 grams, would roughly be a late preterm baby, roughly. And then obviously your preterm kids or kids less than 1,000 grams, they're going to look like emphysemas, right? So the way I always remembered it when I was taking my NPS credential, the neonatal pediatric specialist credential, was that their blood gas should look like someone that has emphysema. It should be high CO2, low pH, and low PaO2. That's exactly what you're aiming for in these super preterm kids. Now, the more the term they are, that's when you get more to normal, like 7.3 to 7.4, 80 to 100 for their PO2, 30 to 40 for their CO2. So those are all becoming more normal. Even the bicarb, 22 to 24, becomes more normal as you get towards a term baby. But the more preterm they get, the more you got to think this is someone that has COPD, even though, right, if that's where your brain normally goes to, where they're more acidic with their pH, higher for their CO2, lower for their PO2, and even their bicarb is going to be the only difference here because their kidneys just aren't producing it yet. So these are values I expect you to look at. I want you to know these because I will, on the test, make sure that you know these by saying, hey, you got this baby, this is their blood gas, what would you recommend? Well, if there's high CO2 and low pH for their gestation, for their preterm or for their term, right, then you would want to do ventilation steps, right? So I'm going to get this out of you, right? So make sure you got this down. All right, so what are some causes of some of the acid-base disorders? So when we're looking at the acid-base disorders, there's respiratory causes, and of course metabolic causes, and then we break it down further into what causes acidosis, alkalosis. So respiratory acidosis, of course, sedation, which we're not using as much anymore. If anything, in the NICU they use the Ativan as a sedation thing, so it doesn't really affect their ventilation usually much, but they can use paralytics, things like that here and there. Not super common though. Bronchopulmonary dysplasia, which would be the lung when we get down to our neonatal lungs, and I think that presentation is also already up for you guys. Meconium aspiration, if a baby's septic, if they are transient tachypnea of the newborn, the kid's hypoglycemic, trauma, pneumothorax, of course, would cause respiratory acidosis, or even a CDH, a congenital diaphragmatic hernia, easily causing respiratory acidosis, smaller surface area. Well, it's metabolic acidosis, hypoxemia that causes lactic to build up. So this would be like a GAP acidosis. Remember we talked about GAP versus a non-GAP acidosis, and a GAP acidosis means that there's a high gradient between cations and anions. So we're looking at potassium and sodium, and then we're looking at that, right? We're comparing the gradient between their cations to their anions. So their anions would be chloride and bicarb, right? So we're adding up chloride and bicarb, and we're seeing what the gradient is. If this gradient is big, if it's greater than 16, if I remember right, then that's a sign that they're adding an acid to their system. So that would be like a lactic acidosis. So that would be a sign of a metabolic acidosis. Malnutrition, diarrhea, right? They're losing fluids. That's going to be a big thing. A renal tubular acidosis. Their kidneys are not functioning the right way. Those are all causes of that metabolic acidosis. That means their body's producing an acid ultimately. Pretty crazy. Respiratory acidosis, something that's causing their body so much stress that they can't compensate and breathe. Respiratory alkalosis down here. Yeah, your vent settings are too extreme. Turn them down. RDS, respiratory distress syndrome. That's us using too extreme interventions. Hypoxia-induced hyperventilation. That's breathing too fast for what's going on. Alkalosis, getting gastric suctioning, so you're taking away an acid, right? If you suck out someone's stomach, which is full of acid, what's going to happen to, here's a different way of saying this. If I have a container of a pH of 7.40, if I have a container and I decide I am going to pull out some of the acid out of this container. So I'll just draw little plus signs, right? Hydrogen ions. So I decide I'm going to extract some of those hydrogen ions. I'm going to take them away from this solution. What's going to happen to the solution? If I take away the acid, the solution's going to become more basic. So now it'll be closer to a 7.50, right? Right, because now there's less hydrogen ions. Well, that's what happens with gastric suctioning, vomiting. If we give diuretics, IV bicarb, it can actually cause an alkalosis because we're changing that ion balance within their system. All right, central venous catheters, so central lines. Usually the umbilical venous line is going to be your most common one in the NICU here. So age and condition, especially if you're working PICU and NICU. Right atrial pressure is going to be the good measurement there. We can look at vascular volume. Remember, I talked about hemodynamics in your previous classes. I love hemodynamics. You should love them too. The more you play with them, the more you'll understand them. So you just have to trust me for now and sort of keep your notes handy. Mixed venous blood gases, they're great, especially saturations when we're looking at people that have sepsis, neonate through adult. That venous saturation can tell us how much oxygen consumption their tissue is going through. So the higher the venous saturation, the less oxygen consumption their tissue is going through, the less significant the infection. Hey, it's something we can trend. If it's getting lower and lower and lower, that means the infection is getting worse and worse. There's more oxygen consumption. That's why there's less left over for the venous draw. All right, so here we can see volume status, which is going to be very important, especially let's say we have a kid that has that was given diuretics after a blood transfusion, and now they have high bilirubin levels, and so this kid might need just a normal saline bolus to help them get back to a normal status, and now they might be, and their pH might be going acidic, so now that might actually help correct their pH, that might help correct their volume status, that might actually help correct their bilirubin issue too. Isn't this crazy? We're just putting it all together in one big picture. You're like, I had no clue what you just said, which is great because all these are recorded and so you can go back. All right, non-invasive monitoring. I like this a lot. Transcutaneous monitoring, why would we use it? So transcutaneous monitoring gives us, and not all facilities have a TCM or a transcutaneous monitor. Transcutaneous monitors go on the baby, and you'll see in these pictures, do you see this giant dot over here? So look at the baby on the bottom left, and you see these, I'll try to circle them, right? See those things? Those are transcutaneous monitors. So you sort of want them in a place that's not too bony, but not too meaty either, is the best way of me saying it. And so the idea here is that we could monitor the baby's gas exchange without drawing a gas, right? So we're going to look at their PCO2 and PO2 without having to draw a gas. So I can see if their CO2 levels are increasing, or I can see if their CO2 levels are decreasing. Now, usually we're watching the CO2 values over the PO2s with the TCM, right? So if the baby's unable to get a blood gas, so in other words, their blood pressure is super low, or they don't have an umbilical line, like in that picture you see there, that baby doesn't have an umbilical artery line, right, that's clamped off. So it also saves time too, right? How quick is it just to look at the monitor versus drawing a gas, sending it to the lab, you know, all that other stuff going on. So it saves a lot of time. It's immediate. I can make a vent setting change and wait 2 minutes till it equilibrates in their system and then sort of see what happens to their CO2 levels. I'm not sampling their blood. So in other words, I don't have to pull blood volume off of the kid. That's big, especially with premature kids. Do they have a lot of blood volume to begin with? And we're already running other labs. We're running CBCs, we're running chems, we're running all this other stuff on these kids. Taking more blood is not the best option sometimes, right? Especially if they're hypovolemic. Let's say their cord was separated, or placental, there was a partial placental abruption or full abruption, and that's why they're early, right? So less risk of infection because we're not having to poke them. So there are a lot of advantages here. Saves time. If we're unable to get a blood gas, we don't have to expose them to infection. We don't have to take blood off of them, especially if they're hypovolemic. So there's a lot of advantages here. And the big thing is going to be looking at, remember, it looks at PO2 and PCO2. The big thing here is going to be looking at PO2. So how does it work? So it works on O2 and CO2 perfusing through the skin, right? It's going to warm up the skin to roughly about 44 degrees centigrade. So it keeps it warm, and that's a question they put on the board exams. It keeps it warm, and it uses a Clark electrode. Well, the Clark electrode, if you remember right, is the one that looks at oxygen. So I always remembered this. And I think I've told you guys this story before. How do I remember the 3 electrodes from blood gas? Well, the 3 electrodes are the Sands, the Clark. My style is not very good. The Clark and the Severinghaus. So the Severinghaus, I see. I think of an old cartoon where Clark Kent, aka Superman, I'll just draw an S there. Superman was fighting a Nazi. So I put Severinghaus as the Nazi. So Clark measures oxygen. So Superman flies in the air. That's why I think oxygen. Severinghaus is CO2, which is evil in the respiratory world. Not evil, but you get where I'm going, right? So I always imagine Superman fighting Severinghaus. So I always remember oxygen, CO2, and sand is where they're fighting, which I always remembered as like a sandy beach that they're fighting on. They're fighting on a beach. That's how I remembered it. Whatever it is that gets you to remember it, but it has a modified Clark electrode, which looks at oxygen. Thanks, Clark Kent. So that way we can sort of see that. It has a modified Severinghaus, which measures CO2. And so that's why we can look at both of them. So the big one that you're going to be trending more is going to be that oxygen CO2 levels. We're going to be looking at that CO2 level. If you're looking at ventilation changes, which most of the time we are looking for ventilation changes, is going to be more important to you. So these electrodes, if you go back to that previous slide, you'll see it's secured to the skin with an airtight seal. So why is that important to you? Because if that seal is broken for some reason, like it starts peeling off of them, then it'll read atmospheric. So if you have the Severinghaus, right, if you see a CO2 suddenly drop on the baby that has it on there, the odds are I would check the site first and see if the little membrane came undone, because there's hardly any atmospheric CO2, right? The CO2 in the atmosphere is very, very low, almost unmeasurable compared to what's in our bodies. So that's something I would check there first. So make sure there's a good seal. If you see an abnormal reading on either one of them, the O2 or the CO2, check the seal, right? Just a word of wisdom. So when we're looking at this, that transducer heats up to about 43 to 45 degrees centigrade. That's a test question for the board exams as well. So it arterializes the skin. It increases it heats up the skin. So what happens when you heat up the skin? Does that increase oxygen consumption or decrease oxygen consumption? You should be like, Derek, I remember you saying way back when in pulmonary A&P that when something's heated up, when metabolism increases, it increases oxygen consumption. Well, of course. So that's when we're looking at the PO2 on this. It can actually read a little bit lower than what's actually in their bloodstream, because we've increased tissue metabolism at that site, so we're consuming more oxygen there. I hope that makes more sense. So therefore the CO2 between the two, CO2 and O2, we're going to be more accurate with looking at their CO2 levels, which most of the time that's what we're primarily looking at with the TCM baby, is their ventilation / pH status here. So more accurate with the CO2 than the PO2. Hopefully that explanation made sense. The oxygen saturation is going to be lower because it's reading tissue oxygenation, not arterial oxygenation. Remember, tissue oxygenation is going to be lower in general because there's such high oxygen consumption with heating it up to 44 degrees, right? Normal body temp's 36.5 to 37.5 for a neonate, and this thing's going at 44 degrees. That's pretty hot there, right? So the CO2 is going to be slightly higher, very, very slightly higher than the arterial CO2 because CO2 diffuses easier across a membrane. So that's why it's going to read slightly higher. So both of these are going to be slightly off. The CO2 and the O2 are going to be slightly off if you were to equilibrate them with an arterial blood gas. Right? So O2 would be slightly lower and CO2 would be slightly higher if you were to compare them to that same baby's blood gas simultaneously. Okay, so that's just something to take a note of when we're looking at these. The big thing is going to be burns, right? And that's the big thing to be aware of TCMs is all the burns that can happen. So they're going to change the sites here and there. You just want to make sure that it's usually every 4 to 6 hours depending on the policy or protocol. But if you walk in and you don't see any issues with the baby and it's in like their upper chest area but not on the clavicle, right? We're talking about that upper pectoral area, that would be a perfectly appropriate location, or the thigh or the upper abdominal area like what you've seen in that previous picture. Those are going to be appropriate areas. So I might ask you in the future which would be appropriate areas. That's what you're looking at there. So we usually change them 4 to 6 hours depending on hospital policy and procedure, so on and so forth. Heating the skin changes the structure. Right, shifts the curve to the right because we're increasing metabolism, right? And so it's going to be a right shift. It'll increase the CO2 production because it's heating up the skin, therefore increasing metabolism, increases CO2 production. That's why the CO2 is going to be slightly higher. Plus, the CO2 diffuses much more efficiently through tissues, right? That's why your carbonated soda is so effective. It's a very good diffuser. Shifts oxygen to the right, heats and vasodilates the capillaries, which means we have a more accurate picture than just looking at a skin sample, right? It will cause the skin to become red in that site. That's what we're looking at here. It causes the skin to look red. Advantage of it, it looks at continuous monitoring for very, very sick children. We can look at their trend, I should say, their CO2 and the O2 levels. That's why I like to use the word trend. It doesn't give us the exact amount that's in their artery, but it tells us if their CO2s are trending more acidic or if their CO2s are trending more alkalotic. It tells us if their O2s are trending up or their O2s are trending down. So it can really help give us a good evaluation of if our baby's getting better, if we need to continue titrating down on our support, or if our baby's getting worse and we need to continue thinking about other steps we may need to take. So we can also use this to detect a PDA, very similar to a pre and post ductal pulse oximetry. Most commonly we'll just do pre and post ductals on these kids, and then I have a resource of that in your Blackboard, so please go take a look at that. Disadvantages of the transcutaneous: it requires 2-point calibration. It will auto cal every time it's moved. Thermal injury, which is burns, is what one of the big ones can. The adhesive tape can cause skin to be torn, like we talked about with taping an ET tube. Like those, especially taking tape off of a baby's skin can just tear it. Loose probe will read inaccurate, right? That's why I said the first thing you do if the number looks weird, look at your patient, right? You should always do that as your first step. Don't look at a machine. If a value looks weird, look at your patient first and then work your way to whatever machine you want to, okay? And that's why you're going to make sure, hey, oh, it's just coming off their skin a little bit there. So this should say ABG, not AGB. ABG. So you still need to attain an ABG for correlation, usually, just to make sure you're pretty close to their real values. In other words, you're getting pretty close to what they're trending. The CO2, so the transcutaneous PT CO2 might read low if there's shock, right? What happens to blood flow to their distal tissues if there's shock, right? Well, their vessels are vasodilated usually, or their delivery of blood flow is very, very low. severe acidosis. The blood pressure is very, very low, so they're not going to get a good sampling. Severe acidosis, of course, which would cause vasodilation and therefore decreased delivery. Hypothermia, of course, that would cause vasoconstriction, therefore decreased oxygen delivery. Cyanotic heart disease, so we're not going to use it on congenital heart shunted kids. Severe anemia, because they need a good blood sample to get it. A skin edema, right, because it goes through the skin. If we're increasing the edema, we're not going to be able to read it well. If our PO2 is over 100, holy cow, right, that's very high. So it's going to read low because there's a big difference. Or if they were given an antihypertensive for pulmonary hypertension, it's going to vasodilate. So we're not going to get a good sample. So anything that affects perfusion, go into the kid other than that PO2 is going to be what will cause it to read low. So the most widely used non-invasive monitor is going to be pulse oximetry. Even kids will send them home, send parents home with a pulse oximeter at night, and that's how we know that the kid is still compensating, or if their oxygen came out of their nose, things like that. And this is just the same. They have these little things where they put them in hats, or most of the time we just put them on their foot. So as you know by now how these work, because we've covered this in previous courses, it just looks at wavelengths. So it's going to shoot a laser and measure different wavelengths. One of the wavelengths is 660 nanometers, the other one's 910 nanometers. One looks at bound hemoglobin, the other one looks at unbound hemoglobin, and it just compares the two, right? Shoots the lasers, comes back, is it bound or unbound, and that's how we get our sample. So big advantages, we don't have to warm up the site compared to transcutaneous. We don't have to warm up any site. There's no need to calibrate it. It's much faster. We have different size probes for patients. The accuracy is very, very good when we have a saturation that's above 75%. So usually this is what you're going to see here is this type of a pulse ox. Most of the time we'll cut off this whole area here. And then we'll just use this sort of soft wrap. It's much better for the skin, less likely to cause pressure issues for the skin. So usually you'll see us trim that and then wrap it around. But always follow your hospital's policies and procedures. Of course, that's my legal disclaimer there. And wrap it around. You want it on the outstep. You want it on the outside of the foot there. You see it sort of on the outside of the foot there. I remember they wanted to do a nocturnal pulse ox for my daughter. To look at like nocturnal desaturation, and she was already on one, but they wanted one that recorded it. And the RT, yeah, put it on her toe, and I'm like, she's too small for that. Like, yeah, put it on her toe. It's where the best perfusion. I'm like, I will put it on the site that gets the best perfusion, which was actually this site. I'm just saying. So get comfortable. She obviously. It went pretty well. It's interesting because the doctor was like, that's the best recording I've seen in a long time. And I'm like, huh. As far as like the quality of the recording, I'm like, because he put it on the right place instead of the wrong place, which would have been the toe. All right, moving on. Disadvantages. The pulse ox, now there are some that differ. So there's some that differ, the different types of hemoglobin, like your Rainbow Sixes, things like that, that can differentiate between the different types of hemoglobin. They're just not as widely used as a recording this, but in general, most of them won't differentiate between oxyhemoglobin, methemoglobin, and carboxyhemoglobin. The big thing that you would be looking at here would be methemoglobin, especially if this kid was on a medicine that is more likely to cause it, like nitric. If nitric is, well, it's not necessarily nitric oxide gas that would cause it. It would be stagnant nitric oxide gas, which would be nitric dioxide or NO2. So that's why if you ever played with a nitric oxide, if you've ever used nitric oxide, I should say, when you see it out there, you'll see a reading that says NO2. That's the bad gas. That's why you always purge, as I'm recording this, that's why you purge the tank, that's why you purge the system before you put it in line with a patient, because that gas, when it's stagnant, when nitric is stagnant, it combines with oxygen and forms NO2 instead of NO, right? So it becomes NO2. Well, it's the NO2 that can cause methemoglobin anemia. or methemoglobinemia. So if a kid's on nitric, or if they didn't purge the tank before they put in line with the kid, that would be something to work on. And their stats would read in the mid-80s. Their blood would be brown, chocolate-like colored. Yeah, it's going to look very, very poor. So methemoglobin, also lidocaine if they're using lidocaine for some reason with these kids. So just be careful. It won't differentiate between those two. There are some newer ones that I think Massimo makes and stuff that do differentiate these, but they're just not in wide use as of yet. Hypothermia makes it difficult to process, of course. If their hands or their toes or their feet are cold, are you going to be able to pick up a good pulse ox? No. And especially at delivery, when we put a pulse ox on the right upper extremity, it's going to be a while before we really get a reading because they're vasoconstricted, because they don't have a good pressure and good perfusion there yet. So hypothermia can play a big factor. Babies move. And that's a good thing. If that baby is moving around, you'll see that the more you work in pediatric medicine too, you'll see a waveform go crazy and you'll be like, oh, that kid's moving around. That's good. But it can cause artifact. And then the pressure necrosis, that's why I talked about in that last slide where we might remove some of that wrap part of the pulse ox because we don't want too much pressure on that area. You got to be gentle with those little things. CO2. This uses it uses analysis to look at gas, to look at their CO2 levels. So remember there's mainstream and side stream. I believe we've covered these in your courses before. Mainstream and side stream. One pulls it and reads it at the monitor. That would be side stream, pulls a purge flow and reads it up there. The other one, mainstream, goes in line with like the end tidal. CO2 would go like directly onto like the ET tube. And it would read it there, and it would be this big blocky like system that can weigh down and extubate a kid. So the difference would be knowing it. So this would be the CO2 detector where it is. So this would be a side stream on the right. Right, so this would be a side stream where it pulls it to an analyzer. Well, you're like, well, that sounds great compared to this thing on the left where it looks like it has this big bulky thing that can weigh down and extubate the patient. Well, here's the deal. Let's say a kid's tidal volume is 6 mLs per kilo and they weigh less than a kilo. And this is purging at 2 mLs per minute. So this is robbing a significant part of their tidal volume just to measure their end tidal CO2. Haha, didn't think of that, did you? So when we're looking at this capnography, traditionally in a neonate population, if they're going to use it, they're going to use a mainstream. And the thought is that, yeah, it could in theory put them at higher risk for extubation. However, the evidence hasn't supported that because we're putting something super heavy and big on their circuit, we pay extra attention and extra care towards it. So it actually hasn't shown in statistics in the data to actually increase the extubation risk. All right, waveforms. Hopefully you remember this from back in critical care techniques. I love end tidal CO2, and you guys know this. So you need to know the waveforms. Usually they won't use end tidal on most babies. They'll use end tidal, as I'm recording this, they'll use end tidal in your kids that have BPD, right? That more of your severe impaired lung function babies. And so that's going to give us more effort into how effective their breathing is. A to B here is looking at their CO2 that's in their dead space, right? Exhaled gas from their dead space. So hardly anything should be in there, especially with neonates. We don't really like having any dead space if that possible. We even trim their tubes 4 centimeters past their gum line, just to make sure it doesn't flop over, cause increased raw, dead space, all that stuff. B to C over here. B to C is we're starting to get gas from their dead space, so their trachea, their main stem bronchi, and we're starting to get alveolar gas that's finally coming in there. C to D is really going to tell us about alveolar ventilation. This is my favorite part of the waveform to look at because this tells me how effective the ventilating is. Right? Because I can push gas into someone and I can let it out, but if I don't see that it's exchanging gas with the bloodstream, what's the point? So C to D is looking at gas being exchanged with the bloodstream. That's my alveolar stage, right? That's my, hey, this is where they're ventilating stage. This tells me how effective I am. So if I see this like shark fin waveform where there's no plateau equals no alveolar ventilation, right? So someone with severe asthma might have this sort of shark fin appearance because their gas is being blocked from going to their alveoli because of the bronchospasm sort of closing off all the tunnels that lead us there, right? So their gas is going to be trapped and they're not going to be able to exhale it, and we're not going to see a C to D. D is where the end-tidal CO2 is actually measured. So if it's measuring at 27 millimeters of mercury, that's where we would see it. And then D to E is where the inhalation begins. So be ready, be prepared with those. I just want you to know this and look at this, because down the road, let's say it's a year from now, you have a patient that comes into the ER and you see shark fin. You're like, well, there's no plateau. That means there's no alveolar ventilation. So what can I do to get alveolar ventilation? I will have done my job. Because you'll be like, yes, I remember C to D. That plateau is important. All right, what does this indicate? Just talked about it. Yeah. Do you see a C to D, right? Is this the shark fin? This is the shark fin. No alveolar ventilation, so we need to do something that improves alveolar ventilation. If it's bronchospasm, bronchodilators, or whatever's causing the bronchospasm, right? It could be mucus plugging, could be a number of different things, but there's no alveolar ventilation going on here, so we need to troubleshoot what are some causes of obstruction. It's an obstructive issue that's going on here. All right, so trends, right? We want to look at trends just like we want to look at other things with labs. A gradual increase in exhaled CO2 might indicate that the baby is hypoventilating. In other words, we're not getting enough gas exchange, or there's more dead space that's being created. Well, this isn't good either, right? So that could be a thing where if they had DIC, right, and they had clots that go on there, well, there might be more dead space that's going on there, right? A sudden decrease in end tidal usually indicates most commonly a leak, secretion, something like that. So that's looking at your patient first and working your way back to whatever monitor machine that you're playing with. If there's no reading whatsoever, the baby might be extubated. Or they might be disconnected from the ventilator, which can happen. Or if you're intubating, it might indicate, hey, they're in esophageal intubation as well. So just make sure you're going through these and understanding them as you use them. End-tidal CO2 is the most underutilized thing I've seen out there. Other types of monitoring, impedance pneumography, I'm not going to test you extensively. Pretty much this is looking at respiratory and heart rates, and this is little strap that goes around the baby's chest there, and it looks at their breathing motion as well as their heart rate, and so we can sort of see that at home. Most of the time they'll just use a pulse ox at home, and then a 3-lead usually looks at respiratory monitoring as well. Electrocardiography is affected by changes in hemodynamics and age, so you'll see a little bit of difference there. You might have to do a neonate EKG, and I'll show you guys how to do that as well, if you don't already know. And then by age 3, their EKG resembles pretty similar to an adult. So there are little things that you'll have to look at, but you might have to do a 12-lead, especially if you're at below the navel, at a hospital where the RTs are doing the 12 leads as well. X-rays. Okay, X-rays. The big difference is between a neonate X-ray and adult X-rays. Well, the carina is going to be one of them. It's going to be higher in the neonate, and it's going to usually be around that 3rd vertebrae, so it's going to be much higher on their film than what you would see with the adult. The heart silhouette is going to be less than 60% of the thoracic width, so it's still pretty big. So adult, if their heart takes up over 50%, we're like, that's cardiomegaly. Well, a kid, because of their heart in proportional to their size is bigger, we want it 60% or less. So we give them a little bit more of a cardiomegaly side, but that's because the heart is just bigger to the thoracic ratio. So heart's bigger to the chest wall ratio, in other words, is ultimately what that's saying. The thymus gland, this is going to be a triangular shape. They might call it a sail sign, like a sailboat, right? and it might be just like right over the heart. Can be mistaken for heart border, atelectasis, or pneumonia, but that's just that thymus gland being big initially. The hilum, this is should see the white streak spanning outward. If you see a lot of these streaks and they have a PDA, guess what? Patent ductus arteriosus, you have pulmonary edema going on. These streaks going away might mean you have a right to left shunt, right? So if you have a kid that has more cor pulmonale and has an ASD or VSD, then that would become a right to left shunt, sending blood to the opposite side and therefore decreasing pulmonary blood flow and increasing arterial blood flow and shunting, right? That's what you would see there. So here are some examples of what you would see. I love this because you can always pause this, zoom in, all that stuff, and look and see. So you can see the aortic arch. So there's 3 moguls. I talked about these in my x-ray presentations. You want to see the aortic arch, right? That's this guy here. You always want to see the the left atrium and then the left ventricle. So those are your 3 moguls that you want to identify. Of course, the trachea, you guys should all see by now. You can see it fan out. You can see the carina here. You see how it is on the left side and the right side. You see how that gradient is still there. That like 45-degree angle compared to 25-degree angle. You see the white streaks. See these little white streaks over here. You want to see some of this. Just too much of it would show pulmonary edema. Now you're like, does this patient have a pneumothorax? No, that's part of the scapula. That's back there, right? Do you guys sort of see that's the shadow of the scapula? That's back there. We're looking at this, the costophrenic angles, just like we were looking at with adults. So go back and look at my old x-ray presentations if you don't remember them. You want to see good CP angles. When someone's intubated, you want to make sure the tip of the tube is even or a little bit below the thoracic inlet. The thoracic inlet, now let me use blue here, is going to be the level of the clavicles. So you want to make sure the tip of the tube is either even or below it. If it's above it, then it's high. They'll call it the thoracic inlet, but the clavicles is your landmark for that one. So hopefully the more x-rays you look at, the more you'll start to identify them and sort of see those big differences as well. All right, so this would be a typical x-ray of an RDS. You look at how immature this baby is. So you can see the ET tube there. Let's go to yellow again. Here I'll draw an outline of the main stem bronchi. The older you get, the more you'll see this clearly, and obviously you can see the ET tube. Here's that radiopaque line, and then the ET tube there. So it's below the thoracic inlet, because look, here's our clavicles up here. It's below the thoracic inlet and above the carina, so we're good to go. Here you see just this ground glass appearance in the lungs. You see how it just looks like that spotty appearance. That's that RDS, that ground glass, just like ARDS on a patient, right? That ground glass spottiness in the lung. Notice the heart to the cardiothoracic ratio is significant. And that's because this kid is so incredibly tiny. This is a very premature kid that we're looking at here. So that's that ground glass appearance. So ET tube's in good position. Ground glass opacities, this is a fancy word. You can see obviously the EKG stickers up there and stuff, but ET tube's in good position. Ooh, pulmonary interstitial emphysema. So if you go to the lung disease presentation, I think I do talk about it there too, but you're going to see how the most compliant part of a neonate airway, so remember in pulmonary NP I talked about the cartilaginous airways, and I said you have the cartilaginous airways, and then I said you have sort of a transition that has no cartilage but doesn't do gas exchange, and then you have your alveoli, right? You have your respiratory zone, so you have your conducting zone, transition zone, and then your respiratory zone, okay? So the transition zone is the area that is going to be the most compliant in some of these premature kids because the alveoli is not making surfactant, so it's going to be very stiff, right? It's not going to want to expand. Well, your conducting zone is not going to want to expand either because it has cartilage as like an exoskeleton. So therefore, the area that's most prone to expand when you deliver a breath to a kid that has very low surfactant, very low compliance, is actually their transition zone. And so when you see all this bubbling, you look at this left lung area, you see all this bubbling that's going on, right? It looks like emphysema. That's why I call it pulmonary interstitial emphysema. It's actually the transition zone that's overdistended and destroyed. It's crazy. And that's what you're seeing here. And so this kid has a right-sided hypoplasia or something going on there. Their tube is transpyloric, so it's a dot pop. Kid has a chest tube. Obviously, you can see the hole there. When we're looking at this is a big, severe case of pulmonary interstitial emphysema. You see all these like Swiss cheese holes just all over the place over here. And that's what you're looking at. Here's that transition zone just destroyed. So that's why we'd like to use low volumes, high rates, because in their lungs, the path of the least resistance is going to be transition zone. And if that area gets destroyed, that's going to cause pretty much like what we see with emphysema. Remember, emphysema, you have just that floppy airway. The alveoli is fine, but what happens when they try to exhale? The airways collapse in, creates air trapping, all that bad stuff happens, right? So not good at all. A pneumothorax, this one's pretty straightforward to see, right? You can see how it just, the lung border there compared to the chest wall there. You see how radiolucent this area is. Pretty just significant pneumothorax that you're seeing here. This kid also has a feeding tube. You want to see a feeding tube snake and terminate somewhere in the stomach area. What you don't want to see is it go like that. That would usually indicate it's probably placed in the wrong place. So pretty significant pneumothorax. So with a kid like this, if it's greater than 10%, we would, or causing physiological effect, we would put a needle in it or a chest tube as well. All right, a congenital diaphragmatic hernia, as you can see, and we talked about, and it was even in the womb video where there was bowel that just formed, and it's most commonly in that left chest wall area, but you can see just all that bowel that's in the left chest wall. So if you're listening to the lung and you hear bowel sounds and you see a scaphoid abdomen, which I talked about in our last presentation, those are all signs of a CDH baby. So what's one of the things that we are concerned about? Well, if you bag a baby or give baby non-invasive ventilation with a CDH, you'll cause gastric insufflation. You'll cause more gas to develop into in the bowels, which will then restrict their lung function even further. So these babies, they're actually intubate right away babies. And in fact, some people will intubate in the delivery room, like right away, like before the kid's technically even delivered. So pretty significant stuff out there.